Groups have much higher fertility. Women without any schooling or literacy report 6.7. In contrast, Yemeni women with secondary or higher level education give birth to about 2.8 children in their lifetime. Who else has very high fertility? Women in rural areas, bearing about 6.7 compared to 4.5 compared to in their urban colleagues. Yemen continues to have one of the highest infant mortality rates in the region, about twice as high as the infant mortality rate in Egypt, for example. Back when this presentation was developed, it was 69. Gracefully, it's gone down to about 59 at this point, while Egypt has gone down a greater percentage, I see, down to about 27. Under 5 mortality rates are similar, reported at 95, also one of the highest in the region, along with Sudan. Maternal mortality is another thing that we really are concerned about with the MDGs. An estimated 365 women die from pregnancy complications for every 100,000 live births. That's more than 4 times the comparable rate in Egypt and more than double the maternal mortality rate in Syria. This also has decreased to about 200 for Yemen and about 82. Not such a big decrease for Egypt. So experts have defined 3 different scenarios, 3 different assumptions for the future, and they fall into the category of red, yellow, and green. The high assumption is fertility rate continues as is, about 5.5 for now, into the year 2035. The UN has a moderate assumption that basically fertility rates decline from 6 to 3 by then. And then the low assumption is based on the national population policy, wishful thinking perhaps, with fertility rate declining to 3.3 in 2025 and 2.1 in 2035. 2.1 is actually replacement level. Using these 3 scenarios, here are the projections. Not surprising. Total population will increase from 23 to 61 million by 35 under the high fertility, to 60 million under the medium, and to 43 million under the low fertility. 43 is even much higher than the current 23. So let's go in now to what are the impacts of this rapid population growth rate for all 3 of the assumptions on the economy, on education, health, and natural resources. Yemen remains one of the poorest countries in the region, right down there with Sudan. Let us now examine the implications of different population projections on Yemen's economic and social development indicators. Yemen's GDP will steadily increase from recorded 3.8 in 2004 to 7.1 in 2024 and remain at that level into the future. This is according to government documents. By achieving low fertility, the GDP per capita will increase about 2.5 times more compared with estimates of GDP per capita in 2008. Today, 5 million persons comprise Yemen's labor force. They're either working or looking for work. Assuming constant labor force participation rates, let us examine the future labor force under different fertility scenarios. Please note that fertility affects the labor force only after 15 years because those who will join the force this year and in coming years have already been born. Yemen's labor force could reach 13.4 million persons in 35 under the high fertility scenario, but only 12 million under the low or moderate fertility scenarios. The difference in the labor force projections between high and low is 1.4 million people. What affects the population growth on students at the basic, what are the effects of population growth on student at the basic level? If Yemen succeeds in lowering its population growth, the number of students will only be about 8 million in 35. If we do not, the number of students will be almost double the projected numbers under low fertility. Will Yemen have enough resources to educate them? In this projection, secondary enrollment is assumed to increase from 26% of the eligible age group in 2004 to 70% in 24. In that case, secondary enrollments would rise to 2.9 million in 2035 with continuing fertility, compared to 1.7 million students in 2035 with low fertility, and 2 million under the moderate fertility. To increase the number of students in the basic level will require a number of teachers to be increased by 2035. Using high fertility, the number of basic level teachers will increase from 125,000 teachers to 490,000 teachers by 2035, compared to 353,000 assuming moderate fertility and 264,000 under low fertility assumptions. The number of secondary school teachers would be 92,000 in 2035 with high fertility and 54,000 with low fertility. The difference, 38,000 teachers. The moderate fertility scenario would require 74,000 secondary teachers. As the country expects to have increased numbers of students in the basic and secondary levels, more classrooms need to be built. By lowering fertility, the cost of construction in new classrooms is lower. The projections assume a recurrent expenditure of about $112 per basic school student. In that case, annual recurrent expenditures would rise from $419 million in 2008 to $1.6 billion in 35, as opposed to a lower recurrent cost and with lower and the moderate fertility. Sorry, I guess I missed something. Oh, I see, it's drawing lines as it goes. So I'm probably behind. So now let's focus on the health sector. In Yemen, there's only one doctor for every 3,700 citizens, compared with other countries in the region which have one doctor for every 500 or 1,000 population. Even assuming the current doctor population ratio remains fixed throughout the projection period, the number of doctors would need to rise to 16,400 in 2035 if fertility remains high, as opposed to 12,000 under the moderate fertility assumption and 11,600 with lower fertility. Were the situation to improve from 3,700 persons per doctor in 2008 to 500 persons per doctor in 2035, the needed number of doctors would be 123,000 in 2035 with constant fertility and 87 with low. How about hospital beds? Assuming the ratio of population per bed drops from 1,549 in 2008 to 1,000 beds population per bed in 2024 and stays at that level for the rest of the projection period, the required number of hospital beds would be 61,000 in 2035 with high fertility, however, lower numbers for moderate and low fertility rates. Due to high population growth and limited resources of health sector, the average medical expenditures is no more than $11.50 per person per year. By increasing health expenditures per person to $25 in 2024, the recurrent health budget would have to increase to over $1.5 billion in 2035, assuming high fertility, and to $1.13 billion with moderate and 1.08 with low fertility. Arable land is very scarce in Yemen. The Millennium Development Goals report indicates that there is an estimated 1.6 million hectares of arable land, of which about 1.3 million is actually cultivated. This means that agricultural land accounts for only about 2% of the total land area of the country. Under the assumptions in the constant fertility projection, arable land per capita would drop from 0.06 hectares per person in 2008 to 0.02 hectares in 2035. However, with low, moderate fertility, arable land per capita would be about 0.4 hectares in 2035. Water, this is a scary one. As stated in Yemen's poverty reduction strategy paper, the growth in population is accompanied by a, quote, critical and multifaceted water crisis. I think that's an understatement. Yemen is one of the water poorest countries in the world. Per capita recoverable water resources were 137 cubic meters in Yemen in 2004, compared to a per capita average of 1,250 cubic meters in other Arab countries, and a world average of 7,500 cubic meters per capita. By 2008, Yemen's per capita water had dropped to 120 cubic meters per capita. The amount of water for each individual in Yemen is expected to drop significantly to only 44 cubic meters by 2035 with high fertility. Per capita water availability under moderate facilities are even lower. The figures show an increased need of the Yemen community for water now and well into the future. Just to ensure that water availability will remain at the 2004 level of 137 cubic meters per individual, 3,075 million cubic meters were needed in 2008, and increasing to 8,392 million cubic meters in 2035 under the high fertility assumption. Water requirements will almost be 3 times as much under the high fertility compared to a doubling under the moderate fertility or even lower under the low fertility assumptions. Bear in mind that current energy produced in Yemen is currently 25% short of what is needed compared to other countries in the region. The amount of electricity per person will be 195 kilowatt per hour in 2008. Electricity per capita will only be 71 kilowatt per hour by 2035 under the high assumption. You see the other assumptions as well. So finally, getting on to the conclusions and the main challenge. Yemenis will have to pay a very high price if the country continues with rapid population growth. There's a very large gap between the high fertility assumption and the low fertility assumption. We know that we do not have enough local and external resources to address the numerous needs of rapidly expanding population. Therefore, we should work hard to help couples who want to limit and space their births and to help, therefore, the nation with its objectives. This is quite a famous old cartoon. It emphasizes what was mentioned in the previous slide. We'll not have enough domestic and external resources to drive the engine of economic growth to address the steep curve of rapid population growth. So ultimately, whether Yemen is able to achieve its goal for social and economic development will depend to a large extent on its future population growth rate and population size. If Yemen were able to provide sufficient family planning services to satisfy existing demand, which would enable it to achieve population growth goals, the population would eventually grow in size to about 53 million persons by the middle of the century. Still, 53 million. And then stabilize at that size. Even under the best conditions, given Yemen's current age structure and fertility, the population would more than double in size over the next 50 years. Socioeconomic development would still move ahead as paced. If the UN medium population projection is realized, the population would eventually grow to about 75 million persons and then stabilize. While developing social and economically in this situation would be more difficult because the slope is steeper, development would continue, though at a slower pace. If, however, Yemen continued on its current path of population growth, the size of the population would continue to grow exponentially into the future, reaching 200 million by the middle of the century. Under this scenario, socioeconomic development would grow at even slower pace until growth outstrips the resources and development eventually stops. The choice is clear. There's a huge unmet need for family planning services. If these services are provided, fertility will be reduced and the population growth rate will slow. It's a simple equation. Now here's some good news, and this is the final slide. The women of Yemen are smart. They hold the key to the future of Yemen as well as they own the key to their own future. 23% of the women are already limiting or spacing their children by using modern contraception, and full 51% want to limit or space their children. This is called unmet need. They lack health services, they lack contraceptives, they lack advice and information, they lack access and cultural and geographic access to family planning services. And this is where the happy coincidence comes in. It's a happy coincidence that women and men, as couples together, can decide to plan their future, space and limit their children. In so doing, they better their own lives and they assure the future of their own children. And simultaneously, they help Yemen as a nation satisfy its own future. Thank you very much. I hope this helps to the cause.
Thank you, Gary. We'll proceed with the next speaker, who will be T.S. Sunil.
Good morning, everyone. Thanks, Richard, and thanks, Jeff, for this wonderful and timely event. And thanks for inviting me for this meeting and giving me the opportunity to share with you all some aspects of reproductive health and what's happening here in Yemen. You may remember some of these numbers from Gary's presentation, but before I get into the details of reproductive health, let me give you a sort of a snapshot of population characteristics in Yemen. As many of you know, Yemen is one of the least developed countries in the world, with a Human Development Index of 0.435, according to the most recent United Nations Human Development Report. And it is ranked 133 among 169 countries, according, again, based on the UN Development Report. Population growth rate is one of the highest in the world, with an annual growth rate of 2.65%, while birth and death rates have shown significant downward trend, as Gary mentioned in his presentation. They still remain high among countries in Middle East and North Africa. One of the interesting points to note is that about half of the population, think about for a second, about half of the population is less than 15 years old, and almost 3/4 of the population is less than 30 years old. Recent estimates show that total fertility rate ranges between 5 to 6 children per woman, and approximately half of the adult population is illiterate, with an estimated unemployment rate approximately 35%. So what is reproductive health? The concept reproductive health is a complex demographic phenomenon which takes into account a multitude of factors, which include the population policies and programs that exist in a given country, age at marriage, availability, accessibility, affordability of contraceptives. It also includes the maternal and child health services available in a given country. And you know that this concept takes into account a number of factors. For this presentation, I'm going to focus on the definition provided by United Nations, which states that reproductive health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity in all matters relating to the reproductive system and to its functions and processes. So I'm going to use this as a framework for at least the first half of my presentation. A close look at this definition provides three broad dimensions. The first dimension states that individuals should have the ability to have satisfying and safe sex life, and they should have the capability to reproduce and the freedom to decide if, when, and how often to do so, which essentially states that deals with primarily the social, cultural, and population policies exist in the country. And the second dimension deals with having access to safe, effective, affordable, and acceptable choice of family planning methods, which again characterizes the availability, accessibility, and affordability of contraceptives available in the country. And the third dimension deals with access, how couples should have access to appropriate healthcare services that will enable women to go safely through pregnancy and childbirth and provide couples with the best chance of having a healthy infant, which essentially deals with the availability and accessibility of maternal care services. So I'm going to focus on these three dimensions of reproductive health, and using available statistics from Yemen, I will try to provide a descriptive picture of reproductive health in Yemen. The first dimension I'm going to describe using 5 measures, which are marriage law, age at marriage, adult illiteracy, abortion law, and gender inequality. And the reason behind using these indicators, they provide structural and societal conditions that exist in Yemen towards defining reproductive health. This asserts to the fact that individual decision-making processes do not occur in a vacuum. To describe reproductive health, one must also understand the context in which these individual reproductive health decisions are being made. Marriage is an universal phenomenon and primarily provides entry into sexual unions for many women. Prior to unification, North and South Yemen in 1990, the legal age at marriage was set for 15 years in North Yemen and 16 years in South Yemen. In 1992, the legal age at marriage was 15 years, and subsequently the minimum age at marriage was abolished in 1999. Despite the recent attention from the media and policymakers regarding early marriage in Yemen, currently there is no legal age at marriage. About half of young women in Yemen are married before the age of 20, and decisions are left to the parents to make their choices. On the other hand, growing proportion of mothers have reported that they prefer their daughters to marry at a later age than they themselves did. The data from the 2 national surveys from Yemen Demographic and Health Surveys conducted in 1991 and 1992 show a very similar pattern regarding cumulative percentage of women married. One can see that the majority of the women were married before age 20, which is roughly about 70% of women married before age 20. And I will come back to this graph again and discuss more about this later on in my presentation. Despite the country's constitutional mandate for basic education, fewer than half of girls between 6 to 11 in rural areas are enrolled in schools. The gender disparity in educational attainment is very clear, and narrowing the gap in gender disparity in education must be one of the top priorities for local government. This also provides a broad picture of the social environment in which reproductive health decision-making is taking place. The disparity in educational attainment between males and females is reflected in the Gender Inequality Index developed by United Nations. This index reflects 3 women's disadvantages in 3 variables: reproductive health, empowerment, and the labor market. The index shows that the loss in human development due to inequality between female and male achievements in these 3 areas. It ranges from 0, close to 0 being women and men fare equally, to 1 which indicates that women fare as poorly as possible in all measured dimensions in Yemen. And you can see that for the last several years, the value of this index is increasing. Abortion is legally restricted in Yemen and cannot be performed in public health facilities. It's only permitted in cases in which it will save a woman's life, when the woman is a victim of rape, or when the fetus has congenital abnormalities. While there are no data on abortion in Yemen, there are few abortions taking place in private facilities, although there are no statistical reports available on the numbers of abortions occurring. Unsafe abortion may lead to serious complications. Complications such as infections and injuries are commonly discussed in the literature in countries where abortion is illegal or safe abortion services are not available. It is clear from these slides that both population policies and social and cultural policies in Yemen are not very conducive for women to make healthy decisions towards their reproductive health. Going to the second dimension of reproductive health, which states that couples should have access to safe, effective, affordable, and acceptable methods of family planning, methods of their choice, I have 3 indicators: proportion of women not using any contraceptives, use of any modern methods, and unmet need for family planning. When you look at the picture of women never used any contraceptives prior to the data points, you can see that the prevalence of contraceptive use in urban and rural areas in 3 different time periods. The use of contraception is not very popular in Yemen, and this is more prominent in the rural areas of the country as compared to the urban areas. Approximately 80% in rural areas and 60% in urban areas never used any contraceptives 2 years prior to the 2006 survey, which is the multiple indicator cluster survey. However, in both rural and urban areas, proportions using contraception are moving in the positive direction. When you look at the proportion of women using modern methods, these methods include pills, IUD, female sterilization, and condoms. In 2006, current use of any contraception was about 28% of currently married Yemeni women, and 19% of currently married Yemeni women were using modern methods of contraception. And the most popular method is pills, which is roughly about 9% of married women were using at the time of the survey. Contraceptive prevalence in urban areas is about 3 times the prevalence found in rural areas. Disparity in contraceptive use varies by education. Percentage of women using any method of contraception rises from 23% among with no education to 34% among women with basic education to 42% among women with secondary or higher education. Unmet need for contraception or family planning methods, which is defined as the proportion of or percentage of fecund women who are capable of producing children, who are not using any method of contraception but who wish to postpone the next birth or who wish to stop childbearing. Just under a quarter of currently married women in Yemen report an unmet need for contraception for both spacing and limiting. Unmet need is higher for women living in rural areas compared to women living in urban areas. It is clear from these slides that the availability and acceptability of contraceptives vary between urban and rural areas. Currently, there is a growing demand for such services in both urban and rural areas of the country. The third dimension of reproductive health deals with couples should have access to appropriate healthcare services that will enable women to go safely through pregnancy and childbirth and provide couples with the best chance of having a healthy infant. And I'm going to use these 5 measures to describe the third dimension of reproductive health, which is the proportion of births taking place at a health facility, prenatal care or the antenatal care services available, the traditional birth attendance, infant and maternal mortality rates. When you look at the proportion of women giving births at a health facility between urban and rural areas, you can see the differentials are pretty significant between urban and rural areas. Just over a quarter of births occurring in the year prior to 2006 survey were delivered at a health facility. This ranges between 17% in rural areas to 40% in urban areas. And socioeconomic status is positively correlated with the likelihood of giving birth at a health facility. Only 9% of pregnant women from the poorest households delivered in a health facility compared to 51% of pregnant women from the richest households. It is also important to note that half of all ever married women who gave birth in the 2 years preceding the survey were assisted with the delivery by a relative or a friend. When you look at the percentage of women who received no prenatal or antenatal care services, it's pretty, again, significant between rural and urban areas. The coverage of prenatal care services by a doctor, nurse, or midwife is relatively low in Yemen, with only 47% receiving antenatal care at least once during the pregnancy. Again, the difference between urban and rural areas are pretty significant. Assistance from traditional birth attendants show that approximately 8% of all births were delivered by traditional birth attendants in 2006, and the gap between urban-rural dependency on traditional birth attendants is narrowing. Infant mortality rate, these estimates are from the international database of the US Census Bureau. It shows that the number of infants who die before reaching their first birthday. For every 1,000 live births. According to these estimated figures, 1 in every 18 Yemeni children, 1 in every 18 Yemeni children die before they reach their first birthday, and 1 in every 13 children die before they reach age 5. Both infant and under 5 mortality rates are higher for children born in rural areas compared to their urban counterparts. The figures for under 5 mortality in rural areas is about 51% higher than the under 5 mortality in urban areas. Maternal mortality refers to the number of women who die as a result of pregnancy or childbirth per 100,000 live births. Maternal mortality rate in Yemen is one of the highest among all the developing countries. The risk of dying during pregnancy or childbirth is 1 in 39 over the course of their lifetimes. And the risk is even higher in rural areas as compared to the urban areas. The high maternal mortality rates are clearly associated with some of the conditions mentioned before, including lack of access to a health facility before, during, and after delivery. So when you look at the previous slides, the third dimension of reproductive health, one can see that there is a significant contrast between urban and rural areas of the country in terms of health-seeking behavior of women, such as using antenatal care and delivering of children at a health facility. Given the divide between rural and urban differentials in Yemen, it is clear that women are more likely to embrace the opportunities exist in urban centers towards better reproductive health, and one could attribute to the inadequate supply of resources, putting women in danger, primarily in rural areas. Perhaps there is an increase in demand for modern services, particularly in urban centers. Now, having seen the characteristics of all the 3 dimensions of reproductive health, the question before us is that, is reproductive health transition a reality in Yemen? To answer this question, I'm going to look into the behavior of young cohort of women interviewed in the 1991, 92, and the 1997 surveys. It is important to see the performance and behavioral patterns of the young adolescents, since this age constitutes a major segment of the Yemeni population. To discuss this further, I'm going to look into the behavior of adolescents, particularly in 3 areas, namely age-specific fertility rate, proportion married, and the use of modern contraception. When you look at the age-specific fertility rates, provides the rate of birth for a specific age group of women. And I tried to collect ASFR for the last 25 years or so. And the purple line on the bottom shows the pattern of births in 2005 based on UN estimates. It is clear that 2005 estimates are significantly lower than the rates for the previous years. It is important to note that the birth rates are consistently lower for younger years, which I believe is a trend in the right direction. However, the pace of decline is rather slow when compared to fertility decline in other Muslim countries in the Middle East and North Africa. And this is the percentage of women married between 9 to 18 years old. Comparing between proportions married between these two time periods, there is a decline in proportion of women married at the younger age groups, particularly 9 to 13, an increase in proportion married in 16 to 18. While I mentioned before that these numbers are well over a decade old, the survey that is underway in Yemen right now would capture this transition in a more clear fashion. Use of modern contraception. The percentage using modern contraceptives between 15 to 24 years old in 1991, 92, and 1997 surveys. There is a clear and consistent increase in contraceptive use among 15 to 24-year-olds in 1997 compared to 1991, 92. Perhaps one could argue that there is an increase in the taste for consumption of modern goods and services. In other words, the demand for these modern goods and services, such as use of modern contraceptives, are showing some positive trend, at least among the younger generation. Just to conclude, it's a popular belief that Islamic societies with the poor and limited resources are often not compatible to adopt reproductive health transition. Against this popular belief, onset of reproductive health transition is underway in Yemen. However, the pace of transition, in particularly fertility levels, is very slow in Yemen as compared to the reproductive health transition in many that occurred in other Islamic countries such as Iran, Tunisia, Turkey, and Lebanon. Given the growing young population in Yemen, I would argue that reproductive health transition is equivalent to the adolescent reproductive health transition. From an economic and human perspective, the growing young population in Yemen is potentially a tremendous asset as they will shape the future for Yemen. Thus, improving adolescent reproductive health is the path to achieving reproductive health transition in Yemen. Based on the national level statistics, there is a growing taste for modern values, goods, and services, including use of modern contraception, better education for children, postponement of marriage, and so forth. In order to further promote these views, the country must engage in meeting these demands, such as education and healthcare services to its citizens. The Yemeni government and the international donor agencies must capture this growing momentum among the younger cohort in order to sustain the science of reproductive health transition in Yemen. Thank you.
Thank you, Sunil. Our next speaker is Dalia Al-Eryani, and her title, the title of her presentation is Lubna's Story, A Glimpse into Child Marriage.
Good morning, everyone. I'm going to be giving you an overview of child marriage in Yemen, but before I do, I'd like to introduce you to Lubna. Lubna is 8 years old. She's a first grader that I happened to meet and speak with while working on the field. She is engaged and is one of many. Data shows, as my colleague was telling you, that over 50% of Yemeni women are married before they reach 18, 14% of them before they turn 14. These marriages can occur as early as 7 or 8 among both the rich and the poor and in rural areas as well as cities. This is Lubna's story. كيف انت يا لبنى؟ كم عمرك؟
سنة.
كم عمرك؟
سنة.
كيف انت يا لبنى؟ كم عمرك؟
سنة.
كم عمرك؟
سنة.
صف كم؟
أول.
تحبي المدرسة؟ كم كثير ولا شوية؟
كثير.
وتشتي تكملي دراسة؟
آه.
وإيش تشتي تقعي لما تكبري؟ تجلسي عند أمك؟ طيب ما تشتيش تشتغلي؟
ما تشتيش تكوني أستاذة أو دكتورة أو
ما تشتي؟ دكتورة؟ من عندكم تعالجي؟
الناس الأمراض.
الناس الأمراض كلهم؟ هذا أنت تقعي دكتورة حالية. طيب سمعت أن أنت مخطوبة صدق؟ إيش اسم خطيبك؟
عبده.
عبده. وتشتي تتزوجي؟ تشتي تتزوجي بعدها لما تكبري ولا ما تشتي تتزوجي خالص؟
أشتيش.
خالص؟ طيب ليش أنت مخطوبة؟
تكلمي مع السبب.
منو دي بلش الخطبة؟
جدي.
جدش؟ وجدش ليه ما يشتيش تتزوجي وعندك صغننة؟ مدري. بس أنت ما تشتيش صح؟ وتشتي تواصلي تكملي دراستك صح؟ تجلسي عند ماما؟ تحبي ماما؟ يلا مع السلامة. Lebanon's situation is reinforced by law and culture alike. Prior to the unification, both the south and the north of Yemen did have minimum age of marriage laws, 16 in the south and 15 in the north. Following unification, the law set the minimum age of marriage at 15, which reflects the triumph of the northern Yemen's more conservative Islamic culture over the secular and Marxist south. In 1999, the civil status law was amended and the minimum age of marriage was abolished. The current law states that a girl or a boy may be married whenever the guardian deems fit, but forbids sexual relations until the girl is mature. This is a stipulation that's difficult to interpret and to enforce and is interpreted by many as the onset of puberty. In February of 2009, the parliament attempted to pass a new law. The new law would place a hefty fine and up to 1 year's imprisonment on any parent who marries their daughter before 17 and their son before 18. The law almost passed, but it was blocked before the president could sign it. In March of the same year, a group of clerks issued a decree against setting a minimum age of marriage law, and the parliament sent the bill to be re-examined by committees on health, the constitution, Islamic law, and human rights. There was in general a huge divide on whether this law should be passed or not. Opponents of the law stated that Islam does not ban child marriage and neither should the law, and that passing such a law violates the rights of those who want to get married. They also stated that children or a girl is mature when she reaches puberty, not when she's 18, and setting a minimum age or a specific age is an unnecessary bow to Western culture. And finally, that these child marriages prevent immoral behavior in society. Proponents of the law stated that children are neither mentally nor physically ready to be married, much less have children, and that child marriage is one of the biggest problems that faces Yemeni women today because of the increased health risks and also because it robs these girls of their right to an education and a normal childhood. Over 2 years later, this law has still not passed. In terms of culture, there's a well-known saying in Yemen that translates to something like, "Trust me, everyone is better off when you marry your daughter off at age 8. This saying, among others, shows that there's a belief that child marriage is a good thing, both for the girl and for her family. People believe that by marrying off their daughters young, they are protecting them from the temptation of premarital sex and sullying the family honor, and also ensuring that they have sons to care for them in their old age. They are also forming strong family and tribal ties as a result of these unions. Child marriage is, of course, also a financial issue. Many poor families view child marriage as a way to relieve themselves of the financial burden that is the girl. They also see an opportunity for financial gain in the form of a dowry. In addition, males who are unable to get married because they cannot afford a dowry may carry out something known as a trade marriage, which is essentially something like, I'll marry your sister, you marry mine, and neither of us has to pay any dowry. In many cases, one or both of the girls in these trade marriages are very young. These families see no real socially acceptable alternatives for the girls. They view education as a bad return on investment because even if the girl is to be employed in the future, any future income will go to her husband's family. Finally, all this is supported by the belief that Islam condones child marriage and delaying marriage would be un-Islamic. And hence, the practice has never really been questioned. In 2008, the USAID funded Extending Service Delivery Project in partnership with Basic Health Services and the Yemeni Women's Union, implemented a community-based intervention titled the Safe Age of Marriage Project in 2 districts in the governorate of Amran. The project worked to foster change in social norms by improving community knowledge of the social and health consequences of child marriage, strengthening community support for keeping girls in schools, and increasing endorsement for delayed marriages by religious leaders, nurse midwives, and other key stakeholders. The project was carried out in 2 districts, Asod and Asoda. These 2 districts are about an hour apart, and they share many common characteristics. The main difference between the 2 is that the road is only paved all the way to Asod. And hence, Asod is a lot more accessible and has had a lot more exposure to the outside world, including to religious groups. As a result, there was a lot more religious resistance in Asod, but eventually it was easier to bring the community on board and also achieve better results in Asod with the help of a prominent religious leader. So to gain a better understanding of the knowledge, attitude, and practices, we began the project by training 40 community educators to conduct a survey of 400 families. We found that the population in these 2 districts is largely illiterate. Only 1% of the women had any type of schooling. We also found that the majority of the mothers were married before they reached 18, and almost 40% of them also had their first child before 18. And we found that 60% of their daughters were also married before they reached 18. So to answer the question of what do girls want, we carried out a focus group discussion with 12 girls ages 9 to 15 in Asod. We found that because of the rigid gender norms that confine women and girls to the private sphere, the girls believed that they could not combine a career with marriage. They had to choose one or the other. Prior to the focus group discussion, these girls had never actually met a woman who was married young, managed to complete her education, have children, and eventually have a career. We also found out that the majority of these girls, like Lubna, aspired to be either teachers or health workers, because these are the 2 professions that are socially acceptable or favored in these areas. Also, the girls had a difficulty identifying female role models, but those who did identified either the local teacher, the local health worker, or their own mother. So the same 40 community educators, 20 male and 20 female, were trained to change the dominant beliefs around child marriage. They came from various backgrounds. Some were health workers, some were teachers, politicians, homemakers, but they all shared a common belief in delaying marriage, and they all had a drive to educate their communities. A lot of these community educators were actually victims of child marriage. They were empowered with knowledge in the health consequences of child marriage, how child marriage is a barrier to education, the social problems that arise as a result of these types of unions. And the main focus of the training involved exercises differentiating between the cultural and religious beliefs in terms of child marriage. These community educators were trained to deliver these project messages through a variety of communication methods, such as community dialogue, plays, poetry, and debates. The messages were delivered through a variety of interventions. The three main activities were the awareness sessions, where the community educators went into the community and tried to initiate community discussion. These awareness sessions were held in various locations, such as community members' homes and in schools and health centers, basically wherever the community was gathered. The sessions were reinforced through the health fairs, or as we called them, the Safe Age of Marriage Open Days. These health fairs were actually an accidental activity. We had originally planned to just rent a mobile cinema from the Ministry of Health and show a movie on child marriage, but the Ministry of Health decided that they did not want to loan us the mobile cinema because this was a controversial topic and they feared that someone would damage their equipment. So these health fairs were an all-day event that included a movie showing and discussion, a lecture by a prominent religious leader, you can see him here in the picture, and a quiz show run by community educators, and we also provided reproductive health services from a mobile clinic. Finally, we targeted the youth through 6 plays that were developed and acted out by students in 6 schools. These were the first plays that had ever taken place in these 2 areas, and hence they were very popular. So naturally, the community educators did face a lot of resistance while carrying out these activities. The first type of resistance, which nobody really expected, was actually political opposition. The majority of the community educators were from the same party, the General People's Congress, and this transformed the agenda of the project into a political one in the eyes of community members from the rivaling party, Islah. As a result, members of the party in Asuda distributed flyers with messages that contradict those that we were bringing forth through our project, and they also disturbed many of the awareness sessions. In Asod, an Islah-funded magazine was distributed, and the community educators were harassed. To overcome this, the community educators stressed that the project was for the benefit of the community as a whole, that this was not a political project, and that in the parliament vote, not all of the members of the GPC had stood with the law, and not all the members of the Islah had stood against the law. The second type of resistance was religious resistance. Many believe that Islam condones child marriage, and the idea of a safe age of marriage or delaying marriage is a foreign or Western idea. This resistance was overcome when a prominent religious leader participated in the health fairs and explained to the community that delaying marriage is not against Islam. On the contrary, Islam stresses one's responsibility for their and their family's safety and well-being, and because there's evidence that child marriage harms the health of a young girl, we are religiously obligated to delay her marriage. Culturally, the community educators found it challenging to initiate discussion around the topic of a safe age of marriage. Because to the community, marriage was marriage. It was not early and it was not late. To initiate this discussion, they also needed to make sure that everyone in the community was receiving the same messages at the same time. This was a little difficult because of the gender divide, and also because the each community educator was assigned to a group of villages. So to overcome this barrier, they created a synergy of their knowledge and worked in teams of males and females that went together to each area and held awareness sessions, and eventually they succeeded in initiating discussion and soon began to hear from the community how they themselves had suffered from child marriage. There were definitely many aha moments throughout the project. One of the most memorable, I think, was a woman who had always thought her 16-year-old daughter was cursed because she had been repeatedly pregnant, but her babies had died every time. Her 20-year-old daughter, however, had healthy babies. After she heard a community educator explain the health risks associated with child marriage, the woman suddenly had an aha moment. She realized that her daughter wasn't really cursed after all. She was just too young to be pregnant. The woman vowed never to marry her daughters off until they turned 18. The community educators doing the work were a dedicated bunch who became the face of the Safe Age of Marriage projects in their regions. People went to them for advice, they asked them for help, and even blamed them when child marriages took place. To illustrate their dedication, I'd like to share with you Ali's story. Ali was one of our most outgoing community educators, and while working out on the field, he met a father whose 13-year-old daughter was getting ready to be married. He sat down with her father, and he explained to him the risks associated with early marriage, and did not stop until the father was convinced that what he is doing is wrong. But sometimes convincing a community member is not enough. The father had already spent part of the dowry and hence couldn't call off the marriage. So Ali saved the day by paying back the dowry, and the wedding was called off. At the end of the project, we conducted an endline survey and found that people's knowledge and attitude towards child marriage had definitely shifted in a positive direction. They believed that by delaying marriage, girls have more opportunities for education, and that delaying marriage empowers them to make decisions within their family, especially regarding health, and also results in healthier pregnancies and healthier children. We learned many lessons throughout the project, but I think the main four were that, one, there is a need to balance political party involvement. We did not foresee this, but when we went out and worked in these rural areas, we discovered that politics were very important, and in the future, to always make sure that community educators, or these teams that are conducting the education or awareness on the field, are from various parties. Also, although we did involve a religious leader in the health fairs, it would have been more beneficial if we had increased the number of religious leaders that were also community educators. We only had 2. And also, it would have been beneficial to train religious leaders in the area to give Friday sermons on the importance of protecting young girls. Although the community educators did end up dividing in teams and pairing themselves into male and female teams, this is a lesson that is crucial because it overcomes the gender divide and ensures that both males and females in the community receive the same information at the same time. Because at the beginning of the project, when only the males or only the females were hearing this, the females would just tell, the community educators, I can't do anything, go talk to my husband. So because her husband wasn't hearing the same thing, there was just that disconnect. Finally, we learned that buy-in from local leaders is very, very important. The project results varied greatly between the two districts, and the main reason was that we had strong buy-in from a local council member in a SOD, but not in a SUDA. So as a result of the project activities and the strong buy-in from local leaders, the community in a SOD took a pledge to ban child marriage. They also took a pledge to decrease trade marriage, which they considered to be a leading cause of child marriage, by lowering the dowry from the equivalent of $5,000 to the equivalent of $2,000, therefore ensuring or making it easier for people to pay these dowries. SOD also appointed their first ever female principal, who was also a community educator. The community educators personally knew of 53 girl child and 26 boy child marriages that were canceled. They also personally knew of 101 girls and 56 boys who returned to school as a result of project activities. Finally, many of you may be wondering what happened to Lubna. Lubna did not live in the districts where we worked. Her mother had heard about the project and came from a nearby district to seek our help to save her daughter's life. She risked a lot by coming, and she risked a lot by allowing us to record an interview with her daughter. The Yemen Women's Union project coordinators took on her case, and although a final solution has not been reached, Lubna is currently still in school, still with her mom, and still, like many Yemeni girls, hoping for a brighter future. Thank you.
Thank you, Dalia, and Sunil, and Gary. I feel like after watching these presentations and looking at the statistics, hearing about the work, I feel like I've gone back a few years to the beginning of efforts in family planning in countries, say, in Asia and then in the Caribbean first, and then in Latin America and North Africa, where stories like this emanated, but then were followed by just enormous successes in terms of state programs, and then and as well the private sector in bringing reproductive health services to the women that wanted them. So from here, we'll open up to questions, and we have some time for that. Anyone want to start? Yes, Roger Mark. And could you please state where you're from and...
Sure, Roger Mark D'Souza from Population Action International. Thanks very much for the three presentations. Wonderful, very informative. Two quick questions. Dalia, was very intrigued to see the results. And I wondered to what degree you had thought about how you might engage any additional religious leaders. Some of the work that I've done in the Philippines in terms of engaging Roman Catholic leaders there was to identify who we considered as positive deviants among these religious leaders who would understand our messages and be willing to work with other religious leaders to get them on board. And I know that you mentioned you work initially with two, and it's important for you to think about how you could engage other religious leaders. So any thoughts on how you might do that? And I wondered, as you thought about reaching out to both mothers and fathers to convince them about the importance of delaying marriage for their girl children, whether you had different strategies to reach out to fathers versus mothers, whether reaching one particular parent was more important, and to what degree you thought about that. And then Sunil, talking with my colleagues here, we were quite intrigued with some of the ideas that you put out, and particularly this notion of a reproductive health transition. You know, we're very familiar with the fertility transition, and we wondered whether you could just clarify for us a little bit more what you mean exactly by a reproductive health transition. How is that different from a fertility transition, and to what degree this is an idea, concept, or approach that is being received and accepted by others? Thanks.
Go first? Okay. Yeah. As far as engaging religious leaders goes, we were actually lucky because the Basic Health Services Project did have a big religious leaders program. And that's where one of the prominent religious leaders that I showed up on the screen, that's where he came from. So there were already religious leaders in the area that were trained on reproductive health and on early marriage. To what extent were we able to bring these community educators into the team? It was a little difficult because a lot of them were already with another project. That's why we only ended up with two, and also because we wanted religious leaders, but we also wanted a mix of other people in the equation. However, there were a lot of the community educators that on their own initiative went to the religious leader in their area and asked them to give a Friday sermon on early marriage. Some did and some did not. As far as mothers and fathers go, when we designed the project, we designed it so that we had 20 community educators that were male and 20 that were female. And the training was the same for both. But once they went out into the field, they tailored their messages, or they tailored the part of the training that they took out into the field according to their audience. For example, for the mothers, the female community educators focused more on health because that's what mothers care about more. Whereas for the male community educators, when they went out into the field, they started talking about the social problems associated with early marriage because that's more of a masculine concept. Also, which parent was more important? I would definitely say it was the father. At the beginning, like I said, we didn't have a pairing system, and a lot of the female community educators were complaining after in the first monthly meeting. We had monthly meetings, and in the first monthly meeting, they were complaining that a lot of the women were just saying, you know, you're telling me this, I understand, I believe you, I've suffered, but if my husband doesn't hear this, this doesn't do me any good. And that's how we had the male community educators go into these areas and team up with the women and give also awareness sessions. The opposite, however, did not happen. The male community educators did not complain that they needed help from the female community educators.
Sunil, before you move on to that one, can I just follow up with one little quick thing on religious leaders? As Fatima mentioned, the Standing Service Delivery Project under USAID funding did have a religious leaders program. And out in the lobby, you can see the monograph called Muslim Religious Leaders as Partners in Fostering Positive Reproductive Health and Family Planning Behaviors in Yemen, a Best Practice. So we've been doing that. We've been working actually in many countries increasingly with religious leaders, not just majority Muslim countries either. We're finding that these people are community leaders. And why would they want to stand on the sidelines of development taking on in their community? They want really bad to participate in it. So giving them a role to participate in development is a good thing, but not to see them as a tool to pass our messages through necessarily. I mean, it's really they should participate for their own sense of need to participate.
Well, going back to your question about reproductive health transition, this is a concept that I developed or sort of a phenomenon that sort of we evolved from the fertility transition framework. But the difference here is that when we talk about fertility transition, we only talk about number of children born in a time period to a number of children born in another time period, just the how many number of children that we reduced over a given time period, simply fertility levels. Whereas reproductive health transition, we take into account, as I mentioned in my presentation, a number of different aspects. It takes into account what is happening with age at marriage, what is happening with the contraception, what is happening to access to healthcare services, what is happening to infant mortality, what is happening to maternal mortality. So if you think about all these different concepts and create an index for reproductive health, then the transition that is taking place in all these different dimensions over a period of time. So it's not only just fertility, but also all the dimensions, the changes that are taking place, all these different factors. And that's what the reproductive health transition is all about. So it's not just number of children born, not just TFR, but all these different factors.
Another question in the back of the room?
Good morning. Prasanna Vernankar with Creative Associates. This question is directed to Dalia, and it's concerning some of the successes that you've had on the project. With regards to your successes in the regions that you mentioned, to what degree, and this is two questions, to what degree did you get the buy-in from the governorate to work into that community? And secondly, how do you envision scaling up and working in other governorates and districts utilizing the same model? Thank you.
Maybe we can take another question as well. There was one down here. Could you wait for the microphone?
Laurie Krieger from the Manoff Group. Please. Okay. It's Laurie Krieger from the Manoff Group. A question for Dalia. Who are the girls being married to? Are these their relatives? Might it be easier to work through families and more sustainable, or no?
Okay, and I'll add a third question to that for actually for Sunil. Is what component of maternal mortality do you think child marriage represents? I think you said that it was about 1 in 40, is it?
Yeah,
around 1 in 40 now, which is not the highest risk. I think Chad is 1 in 13, Afghanistan even worse than that. But in other words, if child marriage could be averted, where do you think those figures would go? You know, just a ballpark estimate. Also, if unmet need for contraception were added into that mix, how far do you think you could go in averting maternal mortality?
Okay, so I'll start. Okay, so as far as buy-in from the governorate, we actually worked with the Yemen Women's Union, and they have an extensive network in Amran, and they also have, and all over the country really, and they also had district offices in the 2 districts that we worked at. So by working through them, we didn't really have to go through the governorate or have to get buy-in from the governorate. They kind of took on that part for us. In terms of scaling up, again, the Yemen Women's Union participated in this project, and they have staff that were trained to carry out or scale up this activity. And as far as I know that they did receive some funding for child marriage, and they actually scaled up the health fairs. They did those in a number of cities or districts. And we also scaled up to 2 new districts after we completed this project, also in Amran and also through the Yemen Women's Union. Second question. Girls being married, it differs. Like, for example, in Lubna's case, she's actually marrying a cousin, and he's not that much older than her. So you do have cases where you have an 8-year-old and a 30-year-old, but then you have, like in Lubna's case, I think her fiance is 12. So you have an 8-year-old and a 12-year-old. The problem with only reaching 2 families is that there's so much social pressure from the community as a whole that some of these families, even if they don't want to marry their daughters off, eventually cave in. Like there was a case of this girl that I met who she was in, when I met her, she was in her last year of high school, and she was the first of her sisters to ever almost complete high school. And the reason was that her father had always wanted them to, go through school, delay the marriages, but he had caved in every single time. And she was his youngest daughter. So this time he held out, and he's like, no, she's completing her education. And we noticed the trend, the same trend kind of happening for the focus group discussion. A lot of the girls from the focus group discussion were the youngest girls in their family. So it's as if there's like a learning process, and these families are getting to a point where they're just saying no. So I think it has to be a combination of both, targeting the community, but then targeting, within the family structure.
Richard, that's an interesting question regarding the impact of age-at marriage and unmet need on maternal mortality rates. Unfortunately, the problem, one of the many problems that as scholars that we face studying about Yemen is not having in-depth data on some of these issues. But when you look at some of these statistics, or at least in the literature, in similar countries, one could attribute to age at marriage and access to services are the 2 primary factors that contribute to the higher levels of maternal mortality. So I really cannot give you a specific figure in terms of how much this would impact or reduce the maternal mortality rates, but the median age at first birth in Yemen is roughly about 14 years. Median age at first birth. So if you think about these numbers, then you can see that that's going to significantly impact maternal mortality rates. And again, unmet need and access to prenatal care services are equally important as well.
Yeah, I should have added that when you look at this risk, which is around 1 in 39, for lifetime mortality during the lifetime risk of pregnancy, lifetime of reproductive lifetime, I should say. Compared to Spain, which is 1 in 4,000, I think, in the U.S. 1 in 2,800, something like that. So it's actually an astounding figure that it's very hard to get your hands around. Any other questions? Fatima?
Hi, thank you for all the presentations. I guess I have a question for Dalia. You spoke about the political, religious, and cultural aspects that sometimes would entice people to marry their daughters at a very young age. Was wondering also if the economic aspect plays any role. You've mentioned in the beginning that both poor and rich families are practicing this, which was a bit striking because other research have shown that in poorer rural areas, this practice is basically much more wider than in urban centers. Also, the other thing I wanted to ask about was also the family size, whether bigger families would be more apt to practice or have the girls marry at a younger age. Thank you.
Another question, yes. I have a few questions. Okay, microphone.
Okay. Aisha Jaman, CDC, Atlanta. I have a comment on Gary's slides. He showed a beautiful slide where educated girls or girls who had some education had a much more lower fertility rate than girls who didn't have any education. And I just want to make sure that it's not just a family planning issue, it's also an education issue and access to education to women. So we need to work on both aspects of it. I also have a question for Sunil. You looked at family planning services, and there was a huge gap between rural and urban centers. And I would like to, and you looked at behavior as well. And just knowing that 50% of the population in Yemen does not have access to healthcare, how much of that is related to lack of access to family planning, and how much of it is behavior? And finally, for Dalia, I was actually quite surprised to see that we had a law at one point in time. And by the way, I am from Yemen. And then to have that disappear. What are the factors that led to the disappearance of that law? Thank you.
Okay, why don't we just take those?
Okay. As far as these marriages occurring among both the poor and the rich, a study done by Oxfam showed that there's not a significant difference because it is, in the end, a belief. Yes, poor, but they did show that in rural areas, this practice was more common. And I think what plays into that is poverty, of course, but I think it's also the level of education in the family and having alternatives, and both these factors are a lot weaker in rural areas. For bigger families, we don't really have any data that shows whether bigger families are more inclined to marry their daughters off early. But if you correlate it with poverty, I guess my best guess would be it probably is definitely a factor. So why was the law amended? I don't know. I tried to find out. I tried to ask a lot of people at one point. So what I heard from someone is that, well, basically, they just took the laws and kind of each party decided what laws they wanted and amended it according to that. So there's no real reason. That's pretty much how it happened.
The rural-urban differentials are pretty significant, and I've seen some of these slides from my presentation. It's quite obvious that access to services in rural areas, it's quite a significant factor, and that's one of the things that I mentioned in my presentation, is that could be one of the major reasons why some of these services, or even that even though there is a demand is increasing for such services, but lack of services is a major issue. And one good example is from Gary's presentation is that the doctor population ratio, 1 out of 3,700, for one doctor for every 3,700 population is kind of a standard. If that is for the nation, I'm sure that the numbers for the rural areas is going to be a lot more than 3,700. So, I mean, there is a very, very strong divide between urban and rural areas, and access in rural areas. Even look at the number of TFR, the total fertility rate is close to 7 children per woman in rural areas compared to roughly between 4 and 5 in urban centers. So clearly there is, not only in terms of access, but also in terms of other characteristics of population, there is a divide between urban and rural areas.
More questions?
On the education question, clearly I think education and family planning are a chicken and egg situation. People who have higher education use family planning more. But I was the health chief in Bangladesh in the late 80s and early 90s where the big transition took place, demographic transition. And the one thing we learned there that is women, even in the absence of education, accepted family planning. And so I think the point is all things are important. Education is obviously important. Who would argue against that? But in terms of reducing fertility, addressing the population growth rate, the most immediate and first step to do is providing safe family planning services to those who want them. Basically, providing girls with schooling, it increases literacy and numeracy skills, which they can use when they later join the workforce. Education can be empowering and can help girls later when they become adults and marry so that they can make better informed decisions with their husbands. I'm reading from a part of the presentation that I didn't even say, but I'm glad you asked the question. Also, staying in school provides girls with other alternatives instead of marrying earlier. Educated women are also more likely to use family planning, but at the same time, contraceptive use, by and large, is the most effective way to reduce total fertility rate.
Yeah, thank you, Gary. It's a good point that I think is becoming more and more evident when you look across countries. You see very different transitions that sometimes where declines in fertility led the way, sometimes where education, women's education particularly, led the way, sometimes where some sort of economic boost led the way and a government took action and used those funds to educate and supply services. So it's hard to tell how Yemen will ultimately come to this, but the chicken and the egg analogy is a good one, and it seems like throughout the Middle East, there is that variation occurring all the time. Was there another question here? Yeah, down the front, and then
Someone in the back.
there was someone in the back.
She's been asking for.
Ben Merritt, Northrop Grumman. Last night I got the latest National Geographic magazine, and a major section there deals with child marriages in Yemen and stuff like that. Wow. So the headlines have caught up with you, unfortunately. Anyway, I'm kind of wondering, you're dealing with one issue and it's largely social in that, but how to combine that with Gary's presentation where you got the little choo-choo train going up and it stops at that top hill there, and all the factors that you dealt with, not just the GDP, but all the way to electricity demands, water demands. Do any people in Yemen, like the people in the parliament and other things, begin to realize that the issue just maybe of how young or their children are getting married and how many children they're having is going to have a tremendous impact on the resources that Yemen doesn't really have? I mean, you look at water and you talk about running out of water. That's going to stop that choo-choo train awfully quick somewhere along the way. So with family planning and stuff like that, is there any kind of message that comes along to the people that, hey, we really need to work hard to, go down to 2.1 instead of 3.3? That's my question.
Yeah, this is Sung Chojan from the Millennium Project, and I wanted to ask you about the policy to set the minimum age of the child marriage. I was wondering what the proportion is of the opponents and the proponents within the Yemen citizens and also the politicians and the political parties, and how the proponents are pursuing the policy and like their potential to pass the law. Thank you.
Okay, I think we'll have to stop there.
It's one more.
We'll do one more?
Yeah, I think
Okay,
she's been asking.
That'll be the last question.
Hi, this question is for Dalia, although Gary Cook started to answer it earlier. I was wondering, from the results of your project where you showed a significant increase by the end in community belief that delaying child marriage increases opportunity for education for the girls, how did you overcome the initial perception that you described that it's a bad return on investment to invest in more education for girls, since, as you said, any income they may earn later on in the workforce would go to their husband's family?
Okay, so for the first question, I guess for our project, we were more community-based. So we did not really deal with issues that have to do with the population or poverty or the GDP. And initially we had thought of putting it in there, but as we discussed it, it seemed like it was an issue that was too complicated for people in the rural areas, in these two rural areas. And also that they have their view is more limited to what's happening in their village versus what is happening nationwide. However, we did have radio spots that discussed early marriage and linked it to population growth. And that's been the trend in general with the Yemen Women's Union. They have been doing a lot of work with linking child marriage to population growth and to the economic outcomes of that. So the Yemen Women's Union is doing that. As far as proponents and how they're trying to move the law or the bill along, there's been a lot of going back and forth. There's a group of NGOs. They're very strong. They're meeting with parliament members, and they're going. They're trying to pass the law. But the issue here is that the bill did pass. There was a draft, and it did pass at the beginning. But then by the parliament pulled it back because there were a couple of individuals. This is not like a huge, number that said no, and just, the majority did say yes. There were just a couple of people, or a few people, I don't know the exact number, that decided to pull this back and quoting that this is un-Islamic and that they cannot pass this as a law. And based on that, that's where the law is. It's still stuck, and they are still working on it. As far as looking at the belief that education is a bad return on investment, we tried to focus their attention away from the economic value of education to a more holistic value of education. We talked about how an educated mother can educate her kids, how an educated mother understands the health of her kids better and can take better care of her children. We talked about how an educated mother also understands her religion better, and this was a huge factor because even in the focus group discussion, a lot of the girls that, they said they talked about their mothers and, my mom's not educated, she can't read the Quran. So we kind of focused more on that and less on, if she gets an education, she'll be making money, because that's just not very realistic in these areas. Did I miss anything? I have a feeling I missed something. Did I miss anything? Okay.
Gary?
I'm good.
Can I go to Ben's question from Northrop Grumman? Is there anybody out there that can address that choo-choo train and help things out? I think not all is impossible. I think certainly in the government there is an active Ministry of Health, there's a National Population Council, there are NGOs that are working, there's a pretty enlightened population strategy. But even more so, I think I referred to the women of Yemen being smart. And I think the demographic transition, which is inevitable in every country, and most countries have all gone through it already. Yemen's just on the tail end, and it's just coming, but it's going to happen. When I started out with my PowerPoint, the draft total fertility rate was 6.1. I updated it to the current Population Reference Bureau, and it was 5.5. By the time we got to Sunil's presentation, it was 4 point something. So the trend is in the right direction. So I think it's a force of nature that will happen, and I think is the international community working with the women of Yemen and the government institutions and private sector institutions of Yemen. Our challenge is to accelerate that as possible, remove barriers from it, make sure the contraceptives are available, the services are there, training goes forward to the very best of our ability. And speaking on behalf of USAID, we're only one donor among many working with the government, but we do have an aid mission there. We have a former health officer in our group right here who was there for several years in the early 2000s. And we're getting a slightly larger budget. Okay, it's small, it's just getting a little bit less small, but we have ambition for some success in helping partnering with it.
No, that's it. Okay, well, I'd like to thank you all. Before we just close this, yes? What was it you were saying? I'm sorry? I don't know. We're
coffee breaks at 11.
The coffee breaks at 11?
Yeah. So we
okay. I was trying to be quick, but okay. Before Jeff asked that question, though, I'd like to thank. I look around the audience. I'd like to thank some people that helped out to assemble the panels, and I'm looking at Fatima Abu El-Asrar, who early on helped us identify some excellent people and stayed with us for the long haul. Also, Ginny Hill will be here later on to speak. And I think there was, and Daniel Egel, who will be here as well to speak. All chipped in and did more than the usual to make this thing happen. Jeff, would you like to ask your question?
I would. Thank you, Rich. It's not a good, well, as you can see, I don't usually stand between the break and hold things up with the caffeine and the sugar. But I wanted to ask the panelists to help us, and particularly as we go and try to kind of translate what we've learned from you and during the day to those who want to just focus on the headlines. If you could reflect on what you think are responsible and then maybe less constructive ways to make connections with these underlying conditions to the broader prospects of as Gary said, the more superficial discussions of youth bulge and the kind of more simplistic explanations for where we are today, but yet understand from, among other things, some of the research that Rich has done, that age structure and stability and some of these questions, there are some really interesting correlations and research there. So if you can talk a little bit about some of the age structure and population questions and how you connect it to some of the questions of stability and the prospects for the broader political context, be very helpful.
Does anybody?
I'll take.
Yeah, it's a tough question. Why don't we handle that with someone before?
Go ahead.
Yeah. Sorry,
You can say something.
No, go ahead.
Thanks for the question. I'm not sure this is an answer to the question either, but I can comment on the fact that USAID does have an overarching strategy in Yemen, which is not health, education, livelihoods. It is an integrated overarching strategy with the objective being stabilization, peace. And so when we have a health program, our health objectives are not necessarily limited to the health indicator changes. They're linked to beyond that, to more stabilization and a feeling of hope for the future, a willingness to participate in the community and to support civil society. Not sure if that answered. That's just kind of one comment on it, being from USAID's perspective.
Well, I think I agree with Jeff. Sorry, Gary. In terms of the future prospects, the way I would see this problem in Yemen is that without much support from the political level or at the institutional level, there are changes taking place at the individual level. Primarily, and again, I wanted to go back to my slides, that when you look at the characteristics, and this is happening without much support from the institutional level, the political level, even though the society is so closed when it comes to family planning programs, sexuality, and all the demographic phenomena, you can see that there is a growing demand for modern goods and services, which I mean contraceptive use, modern contraception, postponing marriage for later years, the crave for having better education. There is, it may be at a very small scale. And that is not how Muslim countries went through transitions, primarily fertility transitions. When you look at Iran, say for example, or Lebanon, or Turkey, there was some support at the institutional level they started out with. I mean, that is not the case in Yemen. Whereas in Yemen, what is happening is that even though without a strong support at the institutional level, there is a growing momentum among the younger population. So if somehow we can capture that and channel their energy towards a better direction, I think that is a worth money spending. So my recommendation is that we should not ignore what is happening there. I think we should try to capture it and seize this momentum, and that may be a way to path to transition.
I guess we have time for one more question.
I'm Carla White from the Extending Service Delivery Project. I was just going to respond to what you said, Sunil, that we've worked pretty closely, ESD and USAID have worked pretty closely to support the Ministry of Health, and they've responded really strongly in terms of developing a whole series of best practices that they're trying to scale up nationally in reproductive health and family planning. And I think we have a good champion in the Ministry of Health. So I'm not familiar with the whole institution in Yemen, but I know the Ministry of Health has really stepped up and become a champion in terms of spreading a lot of best practices that USAID has supported.
Did you have anything? No? Okay, well, I'll just, in ending, I'll just pick up a little bit on what Jeff said. The reason being, there was a presentation here that I did with Matt Burrows from the National Intelligence Council. And the evidence, at least one looks historically at the evidence of demographic change and regimes, that, and it shouldn't surprise many people if one has followed actually fertility decline across the world, that since the 1970s, fertility decline seems to precede the upticks in democracy. And particularly getting to high levels of democracy is very difficult, it seems, historically, without getting to lower fertility levels and to changing the age structure. And it makes sense, and it's just not actually the age structure. It's probably because there's other transitions are going on during this age structural transition. Typically, the accumulation of human capital. Education is easier with when there's fewer kids, and when parents can invest, and when education becomes easy and human capital accumulates, economics seems to kick in, and that feeds back again into demography. So there is this whole chicken and egg process that's going on. So countries like Yemen and Yemen has actually surprising how much sort of legislative democracy there is, despite all the problems that have occurred and are continuing to occur with in terms of political strife. Nonetheless, it seems to be ahead of countries that usually have that age structure. There's very few countries with very high liberal democracy scores that with age structures like Yemen, which is just so young that it's just hard to get your brain around. So hopefully that this will, at some time this will proceed. It's countries, as they proceed in the age structural transition, they become more stable, and we just have to look back at East Asia, where when I was actually in the military, that was where we thought things would go on forever, and things have changed dramatically there, and they're changing, and they change dramatically in Latin America as well. You have transitions are not quite finished, but still you have an enormous economic uptick that people weren't quite expecting, and stability. So I think there is a connection. It still has to be explored. But with that statement, I'll just end the panel and thank the panelists so much for providing so much information in such a short time and responding so well to the questions. And thank you, audience. So can we give them a hand?